President for BOS, past president for KOS. He's senior faculty at Shankara Eye Hospital. He's a professor, and he's managing director and ophthalmologist at Divakar's hospital. And one more thing which we are not aware, probably is very interesting. He's also observer for the meeting from Karnataka Medical Council. So I'll invite him to chair this session and take it forward. Thank you.
Thank you, Dr. Gagan. We'll start the session today. First, I invite the first speaker of this session, practice management session. This is more important, it's a non-ophthalmological session, but it's very important for most of us because we all do start practice, but how to proceed and have good practice, all these tips are important. So I invite Dr. Karthiyani Venkatesh, who did after MBBS and DO from Mysore. She is working at present as in Zamindar's Microsurgical Eye Center for about 8 years. She will be talking on counseling of patients for ophthalmic procedures. So how normally counseling is more important because how we communicate with the patient, how we speak to the patient is more important as compared to the procedure itself, because good communication leads us to a good rapport with the patient, and if some minor complications occurs, they will get used to our explanations. So I request Dr. Karthiyani to start a session, lecture.
Thank you, sir. Good afternoon, everyone. I'm going to talk about counseling before ophthalmic procedures. Now let's look at the why, how, and who and when to counsel patients before ophthalmic procedures. Why do we need to counsel patients before an ophthalmic procedure? According to the International Agency for Prevention of Blindness, more than 70% of the adults report that loss of eyesight would have greatest impact on everyday life. So patients with the information overload available on internet, they have a lot of information which is misconceived. They may lack awareness about the eye conditions, they may have preconceived notions, they may have fears. So counseling helps to educate patients. It helps alleviate surgical fears and helps in psychological preparation of the patient for the surgery. Counseling also helps impart realistic understanding of the surgery and prognosis to make them aware of the surgical procedure and the post-surgical complications. This in turn helps set the right expectations, avoid post-op surprises, make them help make informed decisions and meet their expectations. In turn, this helps in improving the patient confidence, compliance, and satisfaction. So now, how do we go about counseling? What are the traits a person who counsels should have? A good counselor should have empathy, should be an active listener. He should have a right attitude, good communication skills, and should be ethical. And remember, positive body language is very important here. They should make eye contact while talking to the patient. They should maintain friendly gestures, have a relaxed posture. This gives the patient that, okay, he's a good surgeon. The head posture, nodding, and respecting the personal space of the patient and the family members is important while counseling too. Remember, technology is one thing that gives us instant connection. You can connect with anybody, anywhere in the world. But remember, while counseling, keep your phone aside. Keep it in silent. Do not let the counseling be interrupted by a phone call. In case you need to take an important call, remember, there is a patient. So inform the patient or apologize if you have to take a call urgently. And while counseling the patient, give them enough time to listen to the queries, their complaints, and let the patient decide. Give them enough time to take a decision too. There are some situations where in India we have people coming from different parts of the country. We may not know all the languages. We have people coming from different parts of the world for a procedure. So here, how do we go about counseling these patients? Learn some polite expressions, key phrases. Maybe you can learn some anatomical terms in their native language. If there is a translator who's there, speak short, simple sentences. This will help the translator also translate easily. Give them time to translate too. And sometimes you may have to use pictures, simple pictures like how to install eye drops. If there is a family member who's translating for you, then make sure that they're present during all the visits the patient comes to the hospital. And also you can consider learning a new language. It's always helpful. How does one go about understanding the patient perspective? How do you counsel a patient? First, Understand the patient's need and perspective. What is their lifestyle like? What are their priorities? Then provide care accordingly. Repeat to the patient what you're saying to them and ask the patient to repeat back what they understood. This is to assess what all they've captured in your counseling. And finally, respect what the patient decides. Do not have to, convince them again. And make them understand what they should expect before the procedure, during the procedure, and after the procedure. And then, at the end of counseling, the patient should have time and opportunity to ask all their questions and clarify all their doubts. Some situations arise where we need to do a procedure on a child. So counseling children is not easy, it is challenging. It is challenging to explain the procedure to the child, at the same time the adults, the parents accompanying the child. So it is one challenging aspect. So not only are you trying to explain a difficult concept to that child, but at the same time, parents are there with you, who are watching how you are winning the confidence of the child. So, and remember, children they have fewer coping mechanism, and it's natural for them to resist the treatment that you are advising them. Remember, while explaining to a child to avoid certain terminologies like hurt or sting or it'll pain a bit, don't explain so much in these terms. Make it simpler for them. Give them a lot of reassurance when you're doing a procedure on a child, if it's under local anesthesia. For example, a chalazion for a child under local anesthesia. And also at the end, give them a small reward for their bravery and their resilience, maybe a small toffee or a sticker for them. And in most practice today, most of the cataract practice, we have a lot of elderly patients. While counseling elderly patients, what are the few things that we need to keep in mind? Use simple terms. Don't use technical medical jargon talking to the patients who are present with you. Be prepared to repeat yourself multiple times. They may not understand at first go. They may have memory issues. So you may also have to explain it to them in different ways to make them understand what your plan of care is. And if the caregiver or the family member who's taking the decision is present, please make sure that you're not ignoring the patient in the room when you're counseling them. Look at the patient also. Involve them in the loop of the decision making. Give them extra time. This is very important when you're talking to elderly people too. Sometimes we have patients who have disabilities who come for procedures. So suppose you're talking to them, make sure your tone of voice is as normal as what you would talk to a normal patient. You don't have to shout to a person with a hearing disability. Make sure that you are, if they're using a hearing aid, tell them, is it on? Or how else can you make sure that you're eliminating the background noise over there? And if there's a patient in a wheelchair, sit down so you can counsel them easily. You're at the same eye level. And respect personal space. Suppose the patient is in a wheelchair and you want to make the patient come and sit in your slit lamp unit chair, don't try to push the wheelchair. Ask them first, do you need help? Or don't just grab their arm and make them sit. Offer your hand and ask them if they need help or they can manage to do it themselves. These are some of the examples where you're counseling patients with disabilities. Who should counsel? Remember, the patient is making a decision about when he comes to plan a procedure in a hospital, he's deciding from the time he enters the doorstep of the hospital. So it could be a simple security guard who's at the entrance of the hospital to the person who's explaining to them the last minute, whatever drops or the treatment plan to them. So everybody in the team makes a difference while counseling the patient. Of course, when it comes to deciding the technical knowledge, it's better that the doctors do the counseling. And with most people having a high volume of work these days, it is not easy to dedicate so much time. So trained counselors can pitch in and talk about especially the financial implications of a procedure. When should we counsel a patient? As the topic says, counseling before ophthalmic procedure, but it's not over with just before the procedure. Counseling also covers the post-procedure. Remember, after the procedure is over, we need to explain to the patient what was the outcome of the procedure, how they should be compliant with the medication, how they should come for follow-ups regularly to complete the whole treatment and have a fruitful outcome. With this, I like to summarize. I like to complete this saying, while counseling patients, use simple language, no complicated sentences. Easy to understand words is always important. Have a positive attitude. Remember, you will have to adapt to each patient. Each patient is different. Some may take a little longer time to understand what you're trying to explain to them. Some may have to be interrupted in between to bring them back on track. And remember, when you're having counseling a patient, you need to even have a positive body language, making eye contact, smiling, head nodding. All these little things make a big impact. Remember, only 7% of the talking that you do is through spoken words. Rest of it is through nonverbal communication. And like I said, and staying alert. Staying alert, some patients can be difficult to speak with. There may be some situations where they're already in disagreement with you. In these situations, stay there, simply being there and making sure that, you're understanding the patient, make them feel that you're being, they're being listened to. So this helps in making the patient feel comfortable. And if you know that this patient is still not convinced, maybe inform your team members after the counseling is over that, look, there is one patient who is probably somebody who's going to make a problem. So stay alert and fast track this patient and take care that there is no problem in the hospital. And remember, it is teamwork in counseling every patient before a procedure. It's not without teamwork that we can achieve good results. This, I thank everybody. Thank you, boss, for giving me this opportunity to talk. Thank you so much.
Thank you very much, Katyayani, for explaining how the counseling to be done. Is it necessary to tell the complications of the procedure before, while doing counseling?
I think it is important to talk about complications also, because that way the patient is informed. Especially when we're taking a consent, I think it is important to talk about the complications also and tell them about the success rate of the hospital. This way the patient also, and if there is a complication, they should not question us. I think it's better to keep them informed about the possible complications too.
Normally, if the complication is more like 1 in 100, like that we can tell. If it is 1 in rare complications, we need not tell. Like cataract surgery can cause complication and death on the table. That we should not tell like that. Only common complications we can tell, like 1 in 100 or whatever is common complications and minor complications. Thank you very much.
Thank you, sir.
Thank you. Next, I invite Dr. Narpas Solanki to. Madam, please accept this memento from Reggie Thomas, Dr. Reggie Thomas. Dr. Narpas Solanki, the senior ophthalmic surgeon, and he is chief of Solanki Group of Eye Hospitals, and he's doing a lot of work since he was 30 or 40 years in Bangalore, and he's known for his camp surgeries, number of surgeries. We don't know how many surgeries he has done till now. And he's ex-president of Bangalore Ophthalmic Society. And he's talking to us on happy staff, zero attrition, leadership via work delegates, okay, working delegates. We know that to keep the human resources is the main problem with most of the hospital owners like us. And normally if anybody gives more salary, they leave the center and go to the other center. So Dr. Solanki will tell us about how to keep the staff with us with zero attrition. Thank you very much. I request Solanki to go ahead.
Respected Chairman and Moderator, all the people present here. As we know that all these our management things are very boring for the people, but it is very important. They should learn in the life. Because if you don't know how to manage your hospital, your patients, I think it is very difficult. Seeing the clinical is one part, but in a private practice, when you are there, your 50% part should be on management also, because that is where we always fails. Now, to me, the topic has been given, how to make a happy staff and zero attrition via the work delegation. Now, I will put some of the things which is common and which is the reason why I'm going for it, that okay. फिर चला गया. Can somebody help me? So now come to the attrition causes. So there are the 5 types of attrition you can have. The one is the called voluntary. Secondly, what you call involuntarily. Third one is the demographic. Fourth one is the retirement induced. And fourth one is the internal. My topic will be on internal attrition, But I'll just go for quickly with the other causes, just like that. What is the voluntary attrition, which is a common everywhere? And the one is the personal reason, means higher expectation, person want more salary, or his expectation are too high from the hospital. Another is the working hours are not suiting, because we may have the split duty and they say, no, I can't. And then the daily travel, if they are coming from very far distance, in those cases they will say, no, sorry, I can't come. And their family problems, especially with the ladies, what happens that they are having the children, they are having their family, and they want to quit the hospital. That's fine. You can't do anything. Another is the professional reason. If somebody is getting better opportunity somewhere, they want to leave, or they are getting the better payments, they will leave, or higher designation sometimes, which the existing hospital may not be able to give. Then another one is called involuntary attrition. So involuntary attrition means it is from the hospital we are saying no to your employee, say goodbye, we don't want you. These are the most of the things that are not fit for their job, and we are appointed maybe a ward boy or maybe for OT, but once we see them that it is not a fit for the job, then we have to fire him. Another is the dishonesty. In my hospital, I'll tell you that dishonesty is the one. If we come to know that it is not, within a minute, we'll tell him, say goodbye, you can go home, and his 1 month salary, what we have said, we are just paying in their hand and send him. Because I don't want to keep him in the hospital, so he can say in 1 month, he can destroy a lot of things. Another is the bad team mate, means he's not a good team player, then we don't keep the people there. And another thing is the lack of professionalism. If he is not a professional, he is not doing the things properly as per his SOPs, then we have to remove it. And he doesn't want to, don't have the interest to upgrade his knowledge, because in our things, every day we have to improve the knowledge, so he can be an asset to the hospital. Another thing is that why people leave is because of the male-female. Most of the time, what happens if you are, we are having the male-female, the ratio is up and down, then what happens, they say, no, they are teasing me, they are doing something. So you have to keep a very balance about them. Then the ethnic minorities, he's a Hindu, he's a Muslim, he's a Christian, he's this, he's from this side, or some language things are there, and people try to poke the other person and see that he has to believe. Another is the disabled person, what we say that he's a mota, he's a patla, he's a tingu, like that only they go on telling them. So people will say, I can't work here. So another is the look of the person. Like a new and old. This is the major problem in each and every organization. They say, oh, no, I'm a senior person. I'm working this hospital from 5 years, 10 years, 15 years. You are a new person. So they try to see that he should be commanded by him. And where the problem comes to, where the people try to treat or they want to leave our organization. And the experience and the fresh, definitely the people who are having the experience, oh, I've got the 5 years experience, another person is fresh. So they try to overpower him and say, so where the people get attrition. And then my topic is on the internal attritions. So first we have to see that why the people want to leave your organization in the internally, that if they don't get the better payouts or their salary or CTC. So one part is there if you are getting good CTC, but the in-hand salary is less, because they didn't understand that whatever the professional fees is there or their TDS is there, it has to be cut. And they feel, no, I want in-hand salary this much only, which is not possible. So another reason, and another is the lock-up opportunity to grow. If you don't provide them the good opportunity to grow in the organization, definitely people say, no, because I am getting the only one post and they are not teaching me anything, then definitely people will they like to leave. Then the personal dignity and honor. There is definitely everybody want that, yes, my dignity has to be maintained. Everybody should give it the respect and honor and all that. And the security and support. If they feel that is this organization, people are coming and going, they feel that, no, I'm not secure here. And anytime they can fire me. Another thing is the support. You have to give the good support to them. To reduce the internal attrition, first, my suggestions are like that. You have to give the payout which is in the industry's norm. What are the other hospitals of your cadre are giving them? You have to give them, not try to give little bit lesser. You maybe give 1,000, 2,000, you are giving less. But what will happen later on? He'll try to search here and there. So try to give the industry's norm. And if the good and experienced person there, you can give 10%, 20% more also, and try to keep that person in organization, so he should not feel to leave. Another is the timely increments are very important. Many times we'll see 2 years, 3 years, they are not getting any increment. So we have to keep in mind that increment is must, and everybody feel that yes, if increment is there, I will be there. Then performance bonus. We have got the, in our hospital, we give the performance bonus. So in the end, we will have the two type of forms. So one form we give to the employee and say that you write down your, what you have done it. And you have to give this form, and then another with our assessor team will be there. We combine and we feel that he has done some good job, or so we have to give them the performance bonus. And loans without interest. Now, these are the things somebody may like or may not, but we are giving the pay of our employee who are in a trouble. We give the loan and we don't charge any of the interest. Even we are giving their leased house, say 4 lakhs, 5 lakhs rupees, we take a mortgage house and we give it up to that. So at least I know that 5 years he is not going to leave your organization. Another one, we have to help them and in their difficult times, like the school admissions, or they are having in marriages or some health issues are there. So we usually help them and say that you have to pay in the, or from your pay we'll cut the small amount so you will not get hurt. Because most of the time what happens, the school admission comes say, 40,000 beko, 50,000 beko, 1 lakh beko. And we know that these poor people cannot bring that one. So if at that time we help them, they will be our loyal people and attrition will be very less. And as last line I mentioned, if the good and resourceful employees, they give them the extra, maybe 20%, 25%, because if you have trained him and he is leaving, definitely it is going to create a problem. So see that he is an asset for you, and you say first you have to identify that, no, this person is good, he is very honest, in the time he is help us. So please see that he should not leave up to the last. And by giving the proper growth for the opportunity everybody want. So by giving the proper training, we can definitely retain the person, and his interest and capabilities we have to assess that in which department he is having interest. He is having the counseling, or he is having the OT, or he is having the investigations, or he want to do as a PRO. So I think we can do it. Entirely promotion, already I told you. Now work amount is very the flexible time you have to see, and some leniency in the time we have to give. Many times due to whatever the reason, they are coming late. So we should not say, no, yeah, half a day the salary is gone, 1 day salary gone. We try to negotiate, okay, fine, today you're late, but don't come late every time. And then recognition and paid holidays, what we are doing many times, if you want to go with the family out, you can give some amount to support him for his tickets or all that. So he will be said, okay, fine. And paid trainings. This is the one thing we are doing it in our hospital, that we are giving the paid training. He can go to any other places like Madurai. We are sending now, one person has gone to Hyderabad and came back. So this is a way they feel that yes, hospital is helping me to improve my knowledge and skills. And we listen to everybody. Whenever we have the time, we say, we call him, hey, what you are feeling, why about the hospital, what should do it? 3 minutes more, sir. And then comes to staff picnic, take suggestions, give them the respect, and protect him from the unruly employees. This is very important if you want to see that your attrition rate should be low. Because few people are having the habit of, say, giving the pricks to everybody, say, hey, yen madidare, yaake martare, itara martare, hey, new seragi martella. So then what happens, he will get, if you protect them, then they will be definitely with you, and they should have a sense of ownership also. It is my own hospital from where I'm getting the 2-time meals. My family is getting that. So this sense should come. So pre-employment checkup is also very, when we are making them, we are keeping any employee, you have to see what is his past history, how many months or how many years he stayed at one place. If he is going again and again, then you say that this person is not going to be with you. Evaluation is work occupancy. You can put him for 1 day for the one duty and say how really what he says and what he is doing, we will be able to do it. Some do some mock test. Previous payslips you can see to find out whether how much honest he is in telling that my previous salary, what was there. Experience certificates and psychological assessment is also very important. In my practice, only these are the slide I like to tell you. The selection of the right candidate by the proper interview is very important. 3 R's means recognize the person, respect him, and reward him. And 3S is that security, sustainability, and the service is very important. And treat them as a family member, opportunity to grow, and free hand to work, discipline and dishonesty, no compromise. So our track records, I'll give you it in a minute, 30 seconds. I have got about 5 employees which are there with me from last 20 years. About 7 employees for 15 to 20 years, 8 employees. So like that only we are having the lot of the bunch, we are very old people, we are all linear. मैं उनको ऐसे बोलता हूँ कि ये मरेगा क्या? Means you will die here only. But they say, no, sir, till you are there, we are there, sir. This is my own hospital. I am not going to leave at any cost. That gives me a sense of pride that, yes, we have done something for my own employees. So this is my pro team. Thank you very much. Sorry, I took a little more time. Thank you very much.
Thank you, Dr. Solanki. Dr. Solanki, this is a small token of appreciation for you. Could you please come? Dr. Divakar to give away this. Next speaker is Dr. Ellen, who would speak on behalf of, as Dr. Rajshekhar is not here, I think Dr. Ilan? Yes. No need to introduce him. He's the king, boss, and hero of today. So, Dr. Ilan, all yours. Before you start, 1 second, may I request Dr. Soni also to please come up on stage so that we can also proceed faster and easier to introduce people and they recognize your face even before you talk.
Thank you, sir. Good afternoon, everyone. This is a very important topic. We didn't want to skip it. Somewhere down the line, I think all of the ophthalmology societies will say this will be the minimum cost that we are going to. Now we'll study how, what was the journey, how we decided on the cost. When I started my clinic way back in 2004, we did something. But then what we were worried was a situation like this, where instead of the patient queuing in front of us, doctors queuing in front of a patient, don't worry, this is never going to happen. However, particularly in India, it will never happen. However, this is already happening. Thanks to the aggregators, thanks to the chains, with due respect, chains, this is happening. We're just trying to get patients from some other place by reducing the cost. This should not happen. So 2003, when I started, how did we decide on a cost of a consultation? Was it a competitor pricing or scientific costing? None of us knew what the scientific costing was. All of us saw what the competitor down the road was charging, and then tried to keep it 50 rupees less than this. That's why when I started, it was 150 rupees. And when I shifted to the new place, 150 to 250 rupees. MICS had just come in. Everyone was charging 25,000, so I also started charging 25,000. I'm going to show how wrong that was. What is the real profit versus the accounting profit? This is something you should know. What we think is, I've spent so much, I'm taking home so much, that's my profit. No, it's wrong. That also has your own salary as a doctor, as an administrator. So look at what this pricing and profitability is, and then go ahead with it. Now, understand what a fixed cost is, what you spend definitely that month, and what is a variable cost, such as for your consumables. What is your break-even point? You would be paying a loan. You should always consider your salary also into the expenses, and then think of this break-even point. What is the revenue total versus the total collections? And whatever these fixed costs are, can it be converted into variable costs so that we can reduce the cost of the surgery? Most of us use these consultation packages. It's very important that we know all these things. We should know what are the materials used, manpower, how much of this can be outsourced and the cost reduced, and how to reduce the capital cost that we invest. In ophthalmology, it is the highest. All of us work on packages. Remember, if one thing goes extra, we have to pay from our pocket. There's no way we can increase these packages, particularly after we tie up with the insurance companies. And let us not fall for this, where the patient comes and demands us. Of late, it's happening. Some XYZ, is doing all the pre-op cataract investigations free of cost, why are you charging us? Let's not go to this stage. That's why this particular talk has been brought about. Over the next 2 years, we will try to work out along with AAOS to bring a basic minimum costing. Now going into the actual talk, when you look at costing, that is, if I am doing a consultation for a patient, what is the actual cost that I'm spending? What I collect should be more than that. There are 3 different types. Absorption costing, this is normally what we do. Just see what are all the expenses we have undergone, including the rent, the other expenses. Marginal costing, where it's slightly more scientific, where you keep a margin for each of these things, and activity-based costing. Most of the corporate hospitals do this activity-based costing. Simply put, to understand what is this activity-based costing, person is spending 5 minutes at the reception. That activity costs the money. He's waiting for half an hour in your OPD, your AC, your everything else. What is the cost of that? Then comes your optometrist, and then comes your consultation and the rest of the charges. That's activity cost. Hugely scientific, cannot understand. Even here, I've used the marginal costing and not the activity costing, which is called, marginal is also called the mixed costing, where we've used both the sides. Here, we use these in many other hospitals. An inpatient staff is different and an outpatient staff is different. In an ophthalmology hospital, most of the times we share these staffs. So how do we do it? This top-down approach is what I said, that initial absorption costing. Bottom-up method is what approximately you can take it as a scientific method of calculation, but here we will be using a mixed approach where that marginal costing probably comes close to that. I'll show you how it was done. Material, manpower, machinery over the previous year was taken. Previous 2 years was taken, an average was obtained, and looked at all these things, meaning take out the IT what you have filed, probably your CA can give you all these costs, and look at all these indirect costs. Whatever cost you can convert it into, these are all actual costs, permanent costs, you cannot convert it to them. Take all these things, put it as your cost. That is your total cost. That's what I've did it here. This is fixed costs per year, what we're going to sum. Divided by 12 would be per month. Now this is for a small setup where hardly 20 lakh rupees has been spent for a clinic kind of setup. So if you look at it, if you can see 50 cases, hardly the costing comes up to 163 rupees. However, in a small clinic, we cannot see 50 patients. Sometimes even in large hospitals, we do not see 50 patients when we start off. So if you consider that benchmark as 500 rupees or something, or 400 per case, you should be seeing a minimum of 20 patients. So that should be target when you open your clinic. But remember, this is only the cost. So you should add your extra profit to that, which is around 500 rupees. So effective cost in a small clinic becomes 900 rupees. I not kept much more for a larger thing. Here it comes up to around 41 patients if your investment is around 70,000 only in instruments. The rest of the investment comes to this. At least you should be seeing 41 patients. Again, if you have to keep it at around that 900 rupees. These are very simple calculations. You can use the Excel sheet. We'll be circulating this formula later in the BOS group. You can do it yourself and see whether you're really profitable or not. However, the problem comes in larger hospital. Despite seeing 50 patients per day, cost of a consultation will be 725. Most of us, though we claim to be larger hospitals, are in that 50 to 100 category. Very few of us are seeing more than 100 patients per day on a regular basis. So if you have to see for that 400 rupees, a minimum of 90.62, that is around 100 patients you should be able to see. So that's where the costing here becomes 1,200 rupees. This is the costing, All India Ophthalmic Society put it on there. They did a scientific activity-based costing, small, big, and medium-sized hospitals, and arrived at 1,200 to 1,500 rupees should be the cost of the consultation. It's the cost. Over and above that, we should have charged our profits. Somewhere down the line, if we can reach that money, each and every specialty other than ophthalm is charging a minimum of 850 to 1,000 rupees per consultation. It's only ophthalmologists who charge this 400 and 500 rupees. In the OT, of course, there are many more factors that needs to be considered. Most of us run the OT for 3 to 4 hours a day, and people like me run it on alternate days, so rest of the times the OT is redundant, nothing is happening. Now here, when you get the cost, I've written here, right from floor rent, clean room, CSSD instruments. The CMC is what we pay. The first few years, we don't have any CMC, so we don't look into that, and then this problem starts. Each and every company nowadays is charging a CMC, maintenance charges, everything. So these become the first part, and this becomes the consumable part. if you can look at this, if you do 30 cases, initially that's what you will get, even when I shifted. Cost of a cataract surgery will cost around 55,000 rupees. Just think what is the cost we are doing. Many of us are doing at 35. 35 I think is very high. Some of them even at 30. I heard some of them have gone to the insurance and said that they'll do it at 20. Most of these aggregators give you 8,000 rupees to do this surgery. Please don't fall for this kind of traps. Short time, but there will be definitely a larger, at least a webinar on this, so that we can decide on something. What you have seen here are only the costs. If you have to charge a patient and get some kind of profit, at least 25 to 30% for larger, small hospitals, and 15 to 20% for larger hospitals. Whatever figure you see, it should be increased by at least 20 to 30%, depending on the kind of hospitals. From the Ophthalmic Society, we are ready to do it. Medical colleges, well, I don't think we can influence. They are never going to teach us. They are only going to teach us medicine. But then, each of us here as an individual should make sure that this is going to be what we do. Someday in the future, at least we'll be able to achieve it. Remember, before 2012, most of us were charging 200 rupees per consult. We've reached 500, thanks to that effort taken by the BOS MC at that time. I think Dr. Solanki sir and Dr. Ravindra sir were the presidents when this started. All of us agreed, let's move on from here. This 10 years we have been maintaining this 500 rupees. Let's move on from here. Thank you for the opportunity.
Thank you, Dr. Ellen, for that very eloquent and very nice-looking tables. Of course, disheartening to know that we are not making money. Now I call upon Dr. Divakar to speak on the next topic. He'll be speaking on important changes related to the new rules and regulations and the new system of laws which have come into the country.
Good afternoon, everybody. I thank the organizers, the president and scientific committee members and EC committee of Bangalore Ophthalmic Society for arranging this session. I know that it will be nearing the lunch time, so attendance is a little less. You know that India from July 1st, this is coming to effect. There is BNS, that is Bharatiya Nyaya Samhita. About that I'm going to talk today. Normally, medical legal discussions of any of the conferences, it will be revolving around consent, negligence, and professional misconduct like that. About consent, Dr. Reggie Thomas will tell in detail in the next lecture. Normally, in the consent, we will divide our capacity to give the consent to is freely given or by forcible or specific or non-specific or informed written consent, and everything beyond OPD, any touch requires consent. Informed written consent should contain date and time, patient's related name, age and signatures, doctor related name, registration number and signature, witness for the signatures, disease related diagnosis along with the comorbidities, surgical procedure related type of surgery, anesthesia used for the extra consent has to be taken for anesthesia, and blood transfusion, and special risk extra consent need to be for the post-operative ventilation or some other procedures if it is required, and document the fact that the patient and relatives were allowed to ask questions and their queries were answered to their satisfaction. This Bharatiya Nyaya Samhita 2023, it came into effect, passed in the December 2023 in the Indian Parliament, and it came into effect on July 1st, 2024. It replaces the previously existing law, the IPC, enacted in 1816 during the British rule, defined crimes and punishments for all the classes were there in that IPC. It remained in effect till July 1st, 2024. The centre has implemented the new criminal laws effectively from July 1st. The BNS Bharatiya Nyaya Samhita and Bharatiya Nagarik Suraksha Samhita, that is BNSS, and Bharatiya Sakshya Adhyanam BSA were replaced by the Indian Penal Code, Code of Criminal Procedure, and Indian Evidence Act, respectively. Prime Minister Narendra Modi stated that these reforms aim to create the mentality of symbols of slavery and create a new confident India. The government argues that the new law prioritizes justice and fairness over punishment alone. However, legal experts and civil rights advocates have raised concerns about these issues. The new law includes provisions that alter the existing legal procedures. For instance, they have given expanded powers to the police, allowing preliminary inquiries before registering the FIR for the certain offences. Critics argue that this could lead to increased police powers and potential delays in filing the cases. So these are the common things which is, so both, even the lawyers, some states they went on strike for this. These are some of the important points in that BNS which has been changed from the IPCs. In section 30 says that act done in good faith for the benefit of the person who is without consent is not an offence. Nothing is an offence by reason of any harm which it may cause when done in good faith. So what is good faith is it is judged based on the qualification of the surgeon and whether the minimum standard of care is taken or not, and is based on the facts accepted by the peer on Bolam test, where the same standard of care is given, it has to be confirmed by the other peer group. And here care without consent is covered. Here in a good faith and benefit, this action has no intention to cause death. This action is only to benefit or treat the disease. Any hurt to save the life, treat disease is not an offence. Good faith is equal to care of attention. Benefit is not a loss. Good faith for treating the disease is who can only, all registered medical doctors can only claim this good faith for treating the disease. Section 27, consent of the guardian, is in the IPS also it was there, but section number was different. That is act done in good faith for the benefit of the child or a person of unsound mind by the consent of the guardian or the child's parents is not an offence. Example, fever treated with the consent of the father or the mother, child dies after good care and attention is not an offence. Bad outcome despite good care is not an offence. The MI death in a qualified hand at licensed place with the consent after care and attention with good treatment is not an offence. And appendicular perforation consent taken, death after the care and attention is not an offence. Bad cases admitted and treated with consent dies, it's not considered as an offence. Any harm not intended to cause death may lead to death. Raise a risk known by consent, doctor knows it may cause death. Patient agrees to suffer the harm and takes the risk and knows it may cause death. So all this doesn't come under offences. In some emergencies, some treatment has to be done without degree or qualification. Section 19 states that the case done without consent, done quickly, done without any degree, qualification or training, done without any facility or equipment. Big harm is prevented so imminent as to justify or excuse the risky action taken. Act likely to cause harm, but done without criminal intent and to prevent other harm is not an offence. Sometimes in grade 2 and 3 type cities, LSCS may be done by MBBS doctor, caesarean hysterectomy can be done by a general surgeon. In ophthalmology, the criminal cases are quite less actually. There is no criminal intention or knowledge of harm is known to the doer, done to prevent other harm in good faith. Care is guaranteed, but misfortune happens because nothing is an offence which is done by accident or misfortune without any criminal intention or knowledge in the doing the lawful act in a lawful manner is not an offence. Lawfully fire NOC is taken and all the precautions are followed, but accidental fire kills the patient. It is not offence committed by the hospital or the doctor. Lawfully an operation is done, but by bad luck if the patient dies due to MI, it is not an offence on the part of the doctor. It's a wrong diagnosis justified by the peer. Doctor by license makes wrong diagnosis, but if it is justified by the peer or the other professional group in good faith, unrelatedly wrongly, but justified by the peer, patient suffers or dies, it's not considered as an offense. It's any communication done in good faith, that is Dr. A, surgeon, in good faith, communicates to the patient that his opinion that he cannot live, the patient dies in consequence of the shock. This is not considered as an offense, as doctor has told the truth and for the good of the patient. Mistake of fact is in section 14 says, nothing is an offense which is done by a person who is, or by reason of mistake of fact, and not by reason of mistake of the law in good faith, believes himself to be bound by law to do it. Example, Dr. A, qualified doctor, being ordered by the hospital or by the government authority, after due examination and consultation, believing Z to be Y patient, operates on Z. Dr. A has not committed an offense. Example, same names the long list by the presenting staff or the authorities. Evidences in the previously it was in the IPC, it was only written case sheet was taken. Now it is CCTV, mobile phone, audio or video counseling of the unconsent, OT video with consent. All this can be recorded, given as consent, evidences it can be produced in the court. Section 116 and 117 of the BNS deals with the grievous hurt. Qualified doctor cutting a human part of the human body under good faith and for the treatment of the disease, it cannot be held as a criminal under this section. This applies to criminals but not to the healing doctors. Normally in ophthalmology, if we may remove the eye, but somebody may permanent removal of the eye is a criminal offense, but if it is due to some known cause and details are given, then it is not considered as an offense. The offenses come in, BNS come under these sections. He is not a doctor and is unqualified doctor. He conducts some procedures, like it comes under section 114 to 117. The applies unqualified doctors. There may be jail and fine, etc. Every subsection should be read with the exception in BNS. Legally permitted degree with a good training. Illegal is unregistered doctors with prohibited to do. The criminal negligence, gross and rash negligence with severe damage, some hysterectomy causing renal failure, or it is not a licensed and qualified doctor, severe damage occurs and endangering the death of the patient. All these will come under criminal negligence. Doctors are afraid at complaint level only. Courts have maintained a balance between the justice and health service, because medical service is an essential service and a demanding profession. Chances of more false complaints are possible, so we should not worry us. So we should put counter cases for misuse of law. These are some of the questions which came to doctors' minds after the BNS came into effect. Is it true that before the new BNS laws came into force, medical negligence was not a criminal negligence? No, even under IPC, doctors could have been charged with criminal negligence under IPC section 304A, which was a section for the Rash and Negligent Act. In fact, the same section was applied for even rash driving accidents. So what has changed now in BNS under section 106(2) of the BNS, a new category has been created to separate medical negligence from other categories of rash and negligent accidents. So things have they got better for the doctors or not? No. Actually, while it is good that medical negligence is now a separate category, but earlier punishment for rash and negligent acts was imprisonment up to 5 years or fine. Now the punishment for rash and negligent act under BNS is imprisonment up to 5 years and fine. But for a special category, it may be medical negligence, it may be up to 2 years. Thus, the option of punishment by fine alone is now gone, and if you're convinced of negligence, then imprisonment will follow. Hence, BNS is more stringent on us. It's not lax on us. can the police now directly file an FIR of a medical negligence against the medical professional as per the law? No. The Supreme Court, in its ruling in the Jacob Matthews case early, has clearly stated that before filing an FIR in a case of medical negligence, police have to take the opinion of the medical board. The BNS Act does not specify if a procedure to be followed before filing an FIR. It only specifies the sections under which the punishment is imposed. The procedure to be followed has to be as per the Supreme Court guidelines, and hence the Jacob Matthews order still remains valid. So what is next for us? We have to lobby with the government to make changes in the punishment for the medical negligence and restore the option of punishment for medical negligence by leaving only the fees, fine like that. We also need to ensure that the police continue to practice the seeking medical board opinion before filing the FIR in medical negligence cases. How we can do that? Doctors' associations like IMA and other associations believes that there will be a strong NGO lobby which will oppose any concession to the doctors. So we have to be, therefore, to be cautious and get our demands met quietly. These are the BNS sections related to medical practice. Section 88 to 92, offences related to human body, 102, 105, and 106, assault, false certificate, and defamation. These are the laws. Any of the Googles, if you search all these details, the laws will be seen. So IPC section 304 has become 106, causing death by negligence. These are applicable to ophthalmologic. Then 323 has become 115, and 325 has become 117, like that. These are the clauses in the BNS applicable to doctors, hospital, and safety. This can be put in the big banner can be made and put in the hospital. You will see this comparison displayed at the police stations, how the IPC and BNS sections are followed. So thank you for your kind hearing. Thank you.
Thank you, Dr. Divakar. Once again, just to clarify on this 2 or 3 points. One is the new laws make it mandatory that if crime has on criminal medical negligence has been fixed against a doctor, it means that in future the magistrate does not have an option of fine alone, which existed till now. Therefore, the magistrate by force, by this law, has to impose some degree of imprisonment. Though they have made a difference between doctors and the rest of society, doctors it can be from half a day to 2 years. The remaining population will be from 0 or 1 day to 5 years. So though of course it's not significantly different, the court can even say punishable with imprisonment till the end of the day. That means you can be imprisoned or made to stand in the court till the evening, and that itself is defined as imprisonment. So the magistrate is all powerful. It's not that it's a huge difference. 1. 2 is that for an FIR or a criminal case to be registered, that has to be certified not by the judge, not by the police, but by your team of doctors. That means your colleagues have to say that you have created or you have been negligent to a degree of crime. And then only can the police or the court take action against you. So it's not that it's an all new world, it's that your colleagues have to defend you. And if your colleagues say this could be negligence but not criminal, then you're bailed off. You may go to the consumer, he may take you to the consumer court. You may be fined. Now, even if you have a simple thing like a cataract surgery, and instead of a routine cataract, you have a vitrectomy with a dislocated lens or something like that, he can say this is not what I came for and therefore needs a compensation. The consumer court may give him a compensation, but that does not necessarily become criminal negligence. Okay, so that's the key difference that we need to understand. And and who puts that framework of criminal negligence on you? It is your colleagues, it is your doctors, and that panel has to say that you were criminally negligent. Only then does this come into effect. Thank you.
Thank you.
Dr. Soni. Dr. Soni is, of course, I'm proud to introduce Dr. Soni. Before I go ahead, I think I'll request Dr. Soni to please give Dr. Divakar a memento. Dr. Soni will be speaking on customizing practice to suit the setup pearls. Dr. Soni, I'm proud to introduce, is both an MBBS and an MS student of St. John's. He then did his fellowship in anterior segment, and he's an absolute leader in anterior segment surgery, phaco, and has been the CEO of the Vasan Group. He's been the CEO of the Lotus Group, and now he heads the whole of Agarwal's for the whole of Kerala. Yeah.
Dr. Minu, yeah, I have one thing to say. So are our colleagues going to help us when we are in crisis?
That's the multi-dollar question. So you are the ones who are electing people to the KMC. Primarily it goes to the KMC. So you have to decide who you will elect. It's like your government. Will the government help you when you are in a crisis? So it's the same question. So if you have they come to you, they want your votes when they want to get into the KMC. So you need to ask them what happens if there's a thing. Now, if you take off the wrong eye, I'm sure that your colleague cannot help you. But if you have an endophthalmitis after you do a cataract surgery, your colleague can help you, because no textbook, medical science is not a science of pure science which says that when you do a surgery, you guarantee 100% result. Nowhere does any court want it either. Even an endophthalmitis is pardonable because it is known. Textbooks authenticate that this can happen in certain percentage. So that doesn't become a crime. But your colleague has to have the guts to say that, yes, this is not a crime, this can happen even with the best of doctors. So it is your colleague who has to put that statement. Instead, if your colleague says, I think you went there, I think he was negligent, I think, the condition wasn't sterile, then you're a loser.
Okay, now, will I have 2 minutes to speak? Just 2 minutes. So
Okay,
this has
yes.
happened
Done,
with the
please.
former AIOS president.
Sorry?
This has happened with former AIOS president,
Sure, please speak.
Dr. Natarajan from Mumbai. So a case was posted in his hospital for which the laboratory was not recognized by the NABH or whatever. So the histopathology report was reported by a local laboratory, and it was signed by the pathologist, but it was seen by the pathologist, but the signature was that of a technician, for which Dr. Natarajan did not have any role. So when the son of that patient came to know about this, he sued Dr. Natarajan. There was a panel. There were the stalwarts of Mumbai who were the office bearers of the Bombay Ophthalmic Association. And this panel ruled against Dr. Natarajan as negligent for not having that histopath signed by a pathologist within his hospital. And he was made to shell out to the tune of 30 lakh rupees. So what do you say about the colleagues? It was not a case of endophthalmitis, as you pointed out. It was not a case of wrong eye. It was nothing to do with the surgery which Dr. Natarajan performed. And this was shared with me in person. I did not bring it on any forum so far. What do you say for this?
See, what I'm trying to say again is, finally, the authority of whether there is, you can challenge it. The Bombay Ophthalmic Society is not the absolute. You can always take that to the Medical Council of India. So you have a point of challenge, okay? So now, if you are not happy with it, you can challenge it. But there is certain responsibilities of a doctor. Now, somebody just doesn't write one line about it. He will say this was sent to so-and-so lab, while there were other labs available there, while there was this facility available. So there are multiple things which come in before you can put a finger on somebody. And it's not signed by one doctor. It's usually by a panel. So like I said, I and you are nobody to judge why they gave it, why they did not give it. My only contention, my statement is very clear. Your future, your definition of whether you were criminally, grossly negligent lies in the hands of your colleagues. And I know in several situations, including in Bangalore, where our colleagues have gone that extra step to say that it was not negligent. An ophthalmologist colleague of mine from a medical college, I know, they're called as experts. I know not only did he say that there was no negligent, he went to make sure that he knew that the ENT surgeon from his institution may also be called in because the sinuses were involved. He made sure that the ENT surgeon also supported the case and the doctor was exonerated. And that is what we expect of colleagues. Now, if something went the other way around, personally, me, you cannot say why and how. But all we can say, they had the powers.
Shall I add a point?
Please.
You said you have to take an extra step and somebody took it. I wanted to say that let him not take the extra step. Let him step one step behind. Even in the game of cricket, the umpire gives benefit of doubt, LBW, benefit of doubt. When this can be done in a game like international cricket, which is watched by few million people on the stage or on the screen, why did this panel rule against their colleague? I can tell you only one thing. It is nothing but professional rivalry and animosity against your colleagues. Nothing else.
Possible. That is your take on it. I, sitting here, will not comment on it. Sony, topic, please.
Thank you very much, Minu, for this.
Thank you.
Good afternoon. At the outset, let me thank Dr. Ellen and the BOS for inviting me here, and it's such a pleasure being introduced by my own teacher, Dr. Reggie, and sitting next to him and standing here in my alma mater, and with also Dr. Divakar, who was always there with us during my PG times. So I'm talking about something slightly different. So how do you accustom yourself to the kind of practice? Now, you know, grossly, you have individual practices, you have medical colleges, you have multi-specialities with an eye department, which is, slowly going down, and then the corporate way of doing things, and in between comes the family-owned businesses. So, about myself, like I said, I am a Johnite product from St. John's. I did my fellowship. I was a little deviant in the way I went, in the positive sense. I always wanted to be my own boss. It was difficult to work in a big kind of hierarchy. So I worked for a few years, made sure I was comfortable with whatever I wanted to do. I defined myself, and then I had my own practice, almost for 5 years. It was a surgical setup. Then I was lured into joining a corporate. I was, literally pushed into heading a corporate. And after 1 or 2 corporate, then I thought I took a break and went to a multi-specialty hospital with teaching. It was a 1,500 bedded hospital. I was the head of the department there. Then again, I'm back into the corporate setup. So basically, when somebody wants to start their own practice, when to start, where to start, and how to start, these are the million-dollar questions. Out of that, where to start is again, that is about the locality, where exactly you are planning to start. You should confirm yourself. Like if you are happy to, sit in a place, you don't want to grow much. Like you need to have a practice, operate, but have other interests. So you don't want to grow into a big institution, even a small place will be fine. But if you want to really grow, you should select a city or a suburb which is good enough. And how to start? You should start only when you are very confident about yourself. You are sure that you have the sufficient bank balance or the way forwards. And now you have decided, okay, you have to do a homework on how exactly to go about it. So, like I said, when you start, you should define yourself. Okay, how am I going to, now tomorrow I shouldn't be going and comparing myself with a colleague who started a bigger hospital or went into a corporate and compare his earnings and mine. Okay, I am going to go this way. If I am going to start my own practice, okay, I am not looking at the money, okay, I am looking at my satisfaction, okay. And again, if you're going in for a surgery, okay, are you having a pure medical setup or a surgical setup? And if it is a surgical setup, would you want to have your own theatre or you want to share your theatre? Sharing your theatre takes off a lot of stress from yourself because the sterility of the instrument, the sterility of the theatre, etc. takes an extra lot of effort from your side. So sharing becomes better and cost-wise also. Then the budgets, the loans, etc. You should be very clear about your budgeting, how we are going to manage your loans, etc. And the growth. Okay, are you going to start with one doctor? Are you going to have few colleagues supporting you? Are you going to grow year after year and become an institute, or you are going to confine to a certain level? So as a homework, you should visit as many centers as possible. And this gives you an insight, okay, about if every different hospital will have every definite difference in the facilities available, even in how the OT is functioning, the autoclaves, etc., etc. So from all this, you can conclude what is ideal for me, what is comfortable for me. For example, somebody may say horizontal autoclave is the only one, vertical cannot be done. You will see many centers where even a vertical autoclave is being used. So similarly, this will sort out, talk to all those people and get an opinion, take advice from good colleagues and seniors and leaders, not the ones you will know whom to go to. And after all this, you customize your practice and facilities. And regarding the permissions and licenses, you should be very clear about the corporation, the pollution control board, optical shop related and drug license wherever needed. You should clearly know. If you are a husband and wife practicing, you don't need a drug license or a pharmacist, but otherwise, even if there is one more doctor, you need a drug license. And you have agents to do all these things, which you can get from these people. And you should have a working capital. Okay, the initial part of your few months, what you earn is not even going to break even. You need to have that money to pay your staff and keep things running, and even reinvest initially. You should know about the staff pattern. You decide. You don't take 2 people and then after the patients make it 3. No. Initially itself, you should have an idea. The staff pattern also is going to give an impression to your patient. You running around, 2 people running around for the entire show to cut the cost does not help. You should know, have a minimum number of people that will create an impression in the patient. And the growth pattern, like I said, you should have a plan. And you should be ready to catch flies in the beginning. Okay, you would have just finished your training or your fellowship or your junior consultancy, where you have a lot of patients from the hospital side. But then here you have to create your own patient. That doesn't, everybody goes through this phase. And opticals and pharmacy, it's the must-have. This is the one which is going to support you in your initial days financially. And be very clear, making money is not a crime. Okay, and don't be half-hearted or guilty in doing that. Many of us have done it. Reduce the cost because we are not paying as much rent as the bigger hospital. All these things is nothing. If you're delivering what you're supposed to deliver, you should charge well. Not overcharging, but you should be very confident and take this. And Joey Alukas, who's from my state and is the richest jeweler in India right now, I caught him. Debt is not a burden if you know how to utilize it wisely. You should know, when taking a loan is not at all a problem, but you should use it wisely. And marketing, there is immense chance for marketing in-house. It's your own place. You can make your posters, you can make your whatever advertisements inside, and nowadays you can do it externally also. Digital marketing is very cost effective, and you should have an inauguration, and that should be advertised. Okay, don't cut down on that. Whatever budget you have, you should keep. Even if it's the smallest setup, you should do that. Camps, I have my own disagreement with camps being a form of advertisement. Unless you are ready to do free surgeries, luring patients and charging them, I don't think it's a great idea. But there are many corporates who do that. And in the growth, you have to reinvest, advertise, add staff and doctors as a part of the growth. This is how single-man practice or a own hospital should start. Coming on to the corporate practice, which is very important now, it is only for a fully trained doctor. You cannot learn there. Okay? They pay you for your services and you cannot train there. And if they know that you're still trying to, it's a negative on you. And get the best deal in the beginning itself. There is nothing like, okay, after a few years, you get the best deal. And don't expect loyalty from either side, okay? Because it is purely the corporate way of looking at things, okay? It's about, Dr. Ellen had initially discussed about it, how a corporate looks at things. And nowadays the new thing is the investor who's put in 2,000 crores. Now, all the loyalty will go to him. And writing prescriptions, obviously, you may not want to write too many drugs, but then everything is counted in a corporate practice. What is your prescription value? And packages may be high, and there is no charity in a corporate. Okay, it's only seemingly charity, and don't feel emotionally attached to the staff or the patients or the hospital, because all these things are negative for you. If you get, the only thing can happen is you can get uncomfortable, okay? And you should always imagine this can shut shop anytime. So while you are there, do what is supposed to be done, and then decide what you want to do next. The multi-specialty hospital is a good option for a confident fresher who's passed out and his hands are good, okay, he's decided, and who is not ready to invest. Because the hospital pool will supply you. Because there are a lot of patients who come to the other departments, they'll all be, if you have a good relation with your fellow specialties, they will send you. And they are not ophthalmologists. So if you want to do any new procedure, there is nobody who is going to guide you or this thing, you can do it, and you can keep learning on the go. And since the packages, everything can be decided by you, because if you rationally think at it, they'll give you a lot of freedom, and you can have your name, fame, everything. And again, you have to, very importantly, you have to put your foot down regarding equipments. That's the only thing they may not know, and they'll try to bargain. So equipment, get the best equipment you want. Working hours, if somebody is working till 9 o'clock in the night, that's not your worry. You have to have your time, salary increments, and you have to adjust with multitasking stuff. The ENT theatre staff will come and assist you, so you have to be this thing. And you may have to fight with fellow specialties or OT for equipment and OT. And if you prefer a teaching institute with DNB, it is better, especially if you have a flair for teaching also. And doctor or family run institutes, it's again good for beginners, but hard work is mandatory, and you will grow only if you do hard work. And there is an opportunity to turn, and you will have to tune to the management policies there, okay, regarding your choice of IOLs, the medicines, etc. And the growth and projection is proportionate to the loyalty, and there will be the strict monitoring and audit in whatever you do. If you are willing to do all that, it's a good option for you. So in nutshell, these are the various options you have, and this is how you need to tune. Again, making money is not a mistake. It's not a crime. You can always do it if done professionally. Thank you very much.
Thank you, Dr. Soni, for telling us in detail how to start a practice, how to continue the practice, and how to keep up the practice. I request Reggie Thomas to hand over the memento. The next and last speaker for this session is Dr. Reggie Thomas is the next speaker. He is a senior professor and HOD in St. John's Medical College, and he has done postgraduate diploma in medical law and ethics, and he is one of the good speakers related to law and other matters. So I request Reggie Thomas to tell us about the white paper on consent. Consent is one of the important topics which we discuss in our medical legal sessions. So I request Reggie to start. AV, please.
Down, up and down. Okay. Thank you, and I'm not going to keep you long before we disperse for lunch, but I thought this was an important topic. Why I thought it should be a component of this, because to us as doctors, we think that consent is like a trivial piece of paper which must be there, but where it is, how it's handled, what is done is very trivial. It's like going in a bus and you have a bus ticket. You know you need it, but you don't care what is on it. But the truth is that very often it is this small piece of paper or large piece of paper which is within the gist of all your papers, which sometimes may be the most single and vital lifeline in a case that you may face. To the public or to the patient, also, he seems like he's going in a bus, especially when it comes to cataract surgery, because he thinks that every bus will take him to where he wants. He knows that it will reach his destination, and he will get down and he'll be safe. Again, it's a 2-hour travel because he thinks it's like, you know, when you go for a cataract surgery, neighbors have, I've heard they go in the morning, they come back by afternoon. And also, it must be a very simple thing because surgeries are done free. They say no problem at all. My neighbor's gone, got it done. My cousin went, he also had perfect vision. But when I go, they want a huge amount of money for the same 10-minute surgery. But of course, the patient doesn't acknowledge, like when he goes in the bus, that this bus rarely can even have an accident. Okay? And 2, this bus can have other problems. Every person is not the same traveling in that. You can have a heart attack even inside the bus. But after the end of the surgery, if the patient does not see 100% perfectly, if the patient doesn't see as good as his neighbor, if he has a problem with halo or glare, then there's only one person in this world who could have gone wrong, and that is the doctor. And that, like somebody, why is this going by itself?
Auto it is changing, slide change.
Okay, like somebody else said, there are always the people who are ready to add fuel to fire. So what is consent? It is the agreement to what the other person has proposed. Now, here it is the doctor who proposes and the patient has to agree. It is said consent is viewed as the single most ethically important aspect of medical ethics. All of medical ethics is but a footnote to informed consent. Consent is not something new. It was there from the Hippocratic era. Of course, it's had a definition in the last century. The Nuremberg Code came in 1947. The Declaration of Helsinki for Research came in 1964. Informed consent as a term came in 1968. And today we are governed by the NMC regulations, the Consumer Protection Act. And today the Supreme Court of India says that it's not just informed consent, it's prior informed consent. So principles have changed. Doctors are no more gods. In the old era of Hippocrates, it was one of beneficence and non-maleficence, which means that a doctor tries to give maximum benefit and no deliberate harm. But that has changed now, and autonomy has come. The patient decides how much you will do, what you will do, and whether he would like you to do. And it puts both the patient and the doctor on equal platforms. So, if you have not taken the patient's permission for a particular treatment or surgery, it means that you have conducted something which is known as unwanted touching or battery, which is punishable by law. So why is consent so important? Prior consent has become the law of the land. It protects the doctor to a large extent in medico-legal issues. Many medico-legal issues have been lost only because of poor contents of a consent. There is clarity both ways with acknowledged responsibility of the patient. It brings equality and clearly defines today that medical practice is no more a charity, but it's a service which is paid for and you're accountable for. It demonstrates the integrity and respect for autonomy of an individual, which is enshrined in Article 21 of the Constitution. So what are the types of consent? There's implied consent, express consent, and informed consent. There is also something known as surrogate consent, where you can sign, or parents or a guardian can sign on behalf of a child who's below 18 years of age. What is implied consent? The very fact that a patient walks into your OPD or comes into your consultation room, gives you a history, means that he has given basic consent for a consultation. And it stops at that. You may do a few tests like blood pressure or a slit lamp examination. When it comes to express consent, this is when there's a question-answer session. You tell the patient, I think you have this problem. I think you need to do a gonioscopy. I think I need to put some drops and do a fundus examination. And the patient agrees for it. This is oral express consent. When you do something a little more sophisticated, like taking off a foreign body, or you're doing a chalazion, here you would prefer to have it written. And this is called an express written consent. The third, of course, is the most important vital document. It's like a registration in a sub-registrar's office. It's a document you execute. It's a process and not a mere form. Informed consent is a written document of voluntary acceptance of a plan for medical care by a competent patient. It is signed and executed by the patient after having understood the same. It's free of coercion, it's simple and in a plain language. Informed consent is a serious and solemn procedure. Informed consent has 4 vital components for it to be real, valid, and upheld. The mental capacity of the patient should be good, and he should have an understanding of what he is signing. The patient should know what he is consenting to. It should be voluntary, and it should be patient and person-specific and procedure-specific. What are the contents? Dr. Divakar actually put up a small slide. I'll run through it very fast. It must have the demographics, which includes the name of the patient, age of the patient, etc., the name of the surgeon, the planned surgery, the type of surgery, option of the name of the anesthetist, and the date of surgery. Date of surgery, very important. The primary condition with which the patient came with comorbidities, the purpose and nature of the intervention and treatment, which may be diagnostic, surgical, or therapeutic, consequences of such intervention or treatment, alternatives which may be available in-house or outside. Most important, you have to document the risks and known complications involved, like a PC rent, a vitreous loss, and also what steps you may have to take intraoperatively to handle this or postoperatively at a second surgery. The consequences and prognosis of refusing such treatment, the immediate cost of the surgery and future costs in case of complications, and this has to be signed both by the patient and the doctor along with 2 witnesses. Again, date, place, and time to be documented. If that doesn't exist, they will say that you made them sign the form after surgery or on the table. Are printed blanket consents acceptable? No. The court has very clearly said that these are not accepted. So is the AIOS forms which is put across the country accepted? Yes, it's a superb job, but remember, it's only a master framework. It is not your consent for every single patient. One size does not and will not fit all. This has to be individually tailored, filled up, and specific for each patient. You have to have handwritten fillings into that. You can't just have one printed format. Can a patient withdraw consent? Yes, a patient is authorized to withdraw consent at any moment. It can be even on the table as the patient is in for surgery. It can be just before you put your knife. If the patient says, I do not want surgery, there is no surgery. What if you have unexpected findings? Today, of course, surgeries have become much safer, but there have been times at which there have been episodes like an expulsive hemorrhage, the need for a vitrectomy, etc. Will you go ahead with it without documented evidence for it or in your consent? No. You may feel that, poor patient, he'll have to go through another surgery, he'll have to get admitted once more cost. It does not matter. You will not proceed with that surgery. You will close the eye, take a consent, and repeat the surgery. But will you do it if the patient has an MI on the table? You will do everything possible to save the patient because this is life-threatening. Special situations, especially when you have conditions which coexist, like a posterior polar cataract, a subluxated cataract, a traumatic cataract, proliferative diabetic, etc., your consent will be very special. You will add this condition, and even if a patient needs GA, or if the patient has other neurological problems like a stroke, multiple MIs, or if there's a risk of stopping antiplatelet drugs, you will document all this. Because to you it looks okay. The patient will say nothing wrong. But if something goes wrong, everything goes wrong. So, therefore, what should be a doctor's take on informed consent? It's mandatory by law. If something is not documented in your consent, as far as the court and the patient is concerned or the lawyers are concerned, it does not exist. You've never told them that. Therefore, this is the most important and protective document for you in court. And it is important that we save ourselves before we save them. Nothing in the world goes wrong. You would have done, somebody as senior as Dr. Solanki or Dr. Mahabaleshwar should have done thousands of surgeries. 99.9% are happy. But you will have that one patient who will come back and eat your head, which will last you for years. So looks are very deceptive. Protect yourself. A stitch in time saves 9. One medico-legal case for you, you lose money, you lose time, you lose hair, you lose peace of mind, and you're disillusioned as a doctor. Thank you.
Thank you, Roger Reggie Thomas, for the excellent lecture. Any questions from the audience? There are no questions. We close the session. I thank the organizers for giving us an opportunity for conducting this session here. Thank you very much.